All right. I know that we still have attendees joining, but I'm going to go ahead and get started. Welcome. Good morning or good afternoon, depending on where you are. My name is Brian Blaze, and I am the president of Paragon Health Institute. Paragon is a 2-year-old research center dedicated to understanding how government health programs are working and improving policies so that programs better serve American families. We have been fortunate to have long-term care expert Steve Moses join Paragon as a visiting fellow and author 2 papers for us. The first, Long-Term Care, the Problem, and the second, Long-Term Care, the Solution. As you will hear today from Steve and our 2 discussants, long-term care policy is of increasing importance and policy needs reform. To start, a few logistics. First, if you have questions, please use the Q&A panel in Zoom and send those questions along. We'll try to get them answered. Second, the slides from today's event, as well as the video, will be available on our website a few hours after the event. Third, be sure to follow Paragon on Twitter, Facebook, and LinkedIn, and sign up for our weekly newsletter in order to stay up to date with Paragon's research and work. Now to today's program. We are extremely fortunate to have Ken Dykewald as the moderator of today's discussion. Ken is better positioned than really anybody in the country to be the moderator today. He's the founder and CEO of AgeWave, an acclaimed think tank and consultancy focused on the social and business implications and opportunities of global aging and rising longevity. His client list has included half of the Fortune 500. He has served as a fellow of the World Economic Forum and was a featured speaker at 2 White House conferences on aging. Ken has received the Distinguished American Society on Aging Award for outstanding national leadership 3 times, and most recently was awarded the President's Award from ASA. He's a psychologist, gerontologist, and best-selling author of 19 books on aging-related issues, including What Retirees Want, Sages of Aging, and Radical Curiosity. Ken, thanks for your participation today, and I'm turning the event over to you.
Thank you so much. And for those attendees, let me say that the 3 people you're about to hear from are all quite brilliant and may very well be the most knowledgeable folks there are on this subject. So I invite you to take all the things you currently think you know about this issue, whether it impacts your professional work or your family, and listen to what they have to say, and then we'll have some time to explore some of your questions. Let me give a little bit of a backdrop to this theme. As I see it, and I was just commenting in our pre-discussion that I got interested and involved in the field of aging in 1974. So this is my 50th year on this beat. There are 4 unprecedented and converging trends that make this topic so dynamic right now. And they are. First, we're living in a period of elevating longevity. This may sound nutty, but medical anthropologists now tell us that throughout 99% of human history, the average life expectancy was under 18. It's been in the last couple of centuries that we began to live 40, 50, 60, 70 years. Now, living to 70 or 80 is quite commonplace. That was not the case when we were crafting many of the programs in the 20th century for older adults. And by the way, what is an older adult? If we're living longer and longer, when are we old? But we have not set up a version of aging in which our health spans match our lifespans. In fact, we are only 40th in the world when it comes to longevity, we in the United States, but we're 68th in the world when it comes to health span. So that's part of the problem. If there were breakthroughs in the next days or years or decades that would eliminate diseases like Alzheimer's or diabetes or cancer, we might not have so many people in need of care in their last years or decades of life. Second, we're in the midst of an age wave. Demography is both predictable and also often something that people ignore. What we're seeing because of the baby boom after World War II is an age wave. where more and more people are populating the 60s and 70s and 80s of life. And that is not going to change in the coming minutes or years or decades. And so when the boomers start passing their 80th or 85th birthday, the need for long-term care is going to multiply, demographically driven. Third, it's confusing. When I got involved in the field, I wasn't eligible for Medicare. And then when I turned 65, all of a sudden I started getting marketed to by all these different companies, and I had to make a decision about long-term care, which I did, to purchase a private policy because I really didn't know what the situation would be. But if you were to give me $1 million in cash, and after 50 years in the field and 19 books, and say to me, this money is yours if you can explain Medicare, I couldn't do it. So the average person out there simply doesn't understand what their policy covers and what's not covered, and what happens if, and what is Medicaid, and what is long-term care, and what's the difference between long-term care and health care. It's very confusing. And so there are some brilliant people making policies, but we need to make it more user-friendly. And fourth, we're living in a time of breakthroughs. Health monitoring at home didn't exist a few decades ago. There may very well be more scientific breakthroughs. I get emails and I sit on panels continually by people who say that they're, one tick away from being able to use CRISPR to allow us to eliminate some of the diseases that knock people out when they're older. AI may replace physicians because there will be a physician shortage in the coming years as a result of the aging of the boomers having more demand, but boomers make up a lot of the health professional workforce. So with elevating longevity, but the absence of a match between our health spans and our lifespans, with a growing number of older adults, with the choices being confusing and often inequitable, and changes in flux. By the way, I would also add that my company, AgeWave, did a massive survey last year, 10,000 people, 5 generations, and we asked people what their biggest economic worry was, and it was the cost of health and long-term care, number one. So what we're going to do now is hear from the experts, to hear what they think the problem is and what they believe the potential solution is. But I ask all of you attending to keep your minds open, because this topic will, with every day that passes, with every hour that passes, with every minute that passes, this topic will become more substantial, more significant, and you will be dealing with it for the rest of your life. And you probably will also be dealing with it within your own family. I will just say in passing that I grew up in a middle-class, lower middle-class household. My parents were wonderful people. They were married 71 years. My father never imagined he'd become blind and would need long-term care for the last decade of his life. We never imagined my mom would have Alzheimer's and would need long-term care for the rest of her life. And so the cost, which I paid for 2 middle-class people who lived for 12 years needing long-term care, was enormous. Would we have imagined that? No. Let me introduce our first major expert. I've known Steve Moses for over 30 years. He has been almost sort of the lone voice on this going back to the early 1990s, 1980s. Steve is the author of Paragon's Long-Term Care, The Problem, and Long-Term Care, The Solution, which is available to all of you if you've not been to the Paragon website. And he's president of the Center for Long-Term Care Reform, which promotes universal access to top quality long-term care by encouraging private financing as an alternative to Medicaid. Previously, Steve was president of the Center for Long-Term Care Financing. He was the director of research for LTC Inc., a senior analyst for the Inspector General of the United States Department of Health and Human Services, and earlier, a Medicaid state representative for the Healthcare Financing Administration. Steve, tell us what this looks like and what the solutions might be.
Well, thank you, Ken, and I want to welcome everyone and thank you for participating in today's discussion. Long-term care in America is broken. It's marked by nursing home bias, too little home care, dubious access and quality, inadequate funding, caregiver shortages, stressed out unpaid family caregivers, and growing complaints of structural racism. Everyone bewails these problems, but few ask or explain their cause. Most jump to solutions that involve more government money and regulation, but arguably government money and regulation cause these problems. Certainly, Medicaid is at their root. Medicaid reimburses providers 70% of market rates, too little to ensure access and quality. Resulting low salaries cause caregiver shortages and worsen the burden on families. Federal law underwrites Medicaid's nursing home bias and impedes home care alternatives. Medicaid's impact is much greater than its 42% contribution to LTC spending implies. By requiring recipients to contribute their incomes, Medicaid shifts costs to the private sector. It relies heavily on recipients' Social Security income and on Medicare, which pays higher reimbursements, enabling Medicaid to pay often less than care costs. This arrangement is unsustainable. The boomer generation starts turning 85 in 2031, when their LTC need is greatest, just as Medicare and Social Security face statutory cuts. With higher caseloads, less revenue from Social Security, and reduced Medicare payments, rising Medicaid expenditures will constrict budgets, further impairing providers' ability to deliver good care. What caused Medicaid's dominance that created these problems? Policymakers sought to provide a safety net for the needy, but they created a financial failsafe for the elderly instead. A program reputed to help only low-income people who have spent down their savings for care is actually available to higher income people who preserve most of their wealth. As a rule of thumb, monthly income below the cost of a nursing home is not disqualifying. Most large assets, such as home equity, are exempt. Any remaining countable wealth is removable by purchasing exempt assets. And if eligibility is still out of reach, legal advisors extend it to affluent clients by means of trusts, annuities, and other financial strategies. What has this system wrought? By giving publicly financed LTC to the middle class and affluent late in life and allowing them to preserve wealth, it encouraged consumers to ignore the risk early in life. It indemnified them against the worst consequences of failing to prepare. In other words, Medicaid created a moral hazard that discouraged early and responsible LTC planning. Despite constant warnings that aging Americans are dying broke, few people plan for LTC. Private insurance languishes. The high out-of-pocket costs that CMS reports are deceptive. Most are payments from income, not assets, toward the cost of care for people already on Medicaid. If you back out all other LTC payment sources, what remains that could possibly come from personal savings is only 6%. Taking all this into account, we concluded that to end LTC's problems would require ending Medicaid as a late life wealth preserving funding source for all but the truly indigent. The solution is to convert Medicaid into the program most people think it was originally intended to be, and many claim it still is, a safety net for people actually impoverished by private LTC costs. To achieve that objective, we propose to end all Medicaid rules that enable people with substantial income and assets to qualify. On the income side, that means eliminating the medically needy method of determining income eligibility and stopping the use of income diversion trusts in income cap states. All private income would remain in the private pay system instead of coming to providers at harmfully low Medicaid rates as now. On the asset side, we propose to eliminate the ways people qualify for Medicaid benefits while preserving wealth. Purchase of exempt assets to reduce countable resources is the biggest of these and the least understood. The home equity exemption over $1 million in some states should disappear entirely. The look-back period for asset transfer penalties should be 20 years instead of 5. Legal schemes to remove wealth from LTC spend down should end. Now, phase these changes in gradually. Exempt everyone too old or infirm to adapt and prepare. People 55 and older and younger people with chronic disability or early onset dementia would be unaffected. Tell others that Medicaid eligibility rules have changed. There is no way to fund LTC and preserve estates going forward without taking personal responsibility. So they should prepare now in case they need care later. Private firms can estimate individuals' risk levels actuarially, giving each a planning goal to achieve by a date or age certain. People who prepare for LTC risk at younger ages could have a lower goal set. Is this plan draconian? No more so than the way Medicaid is described today as requiring catastrophic spend down into total impoverishment. Consider the plan's benefits. Consumers would prepare for LTC instead of ignoring that risk until they need care. Fewer would rely on Medicaid, substantially reducing numbers of high-cost dual eligibles. Reduced Medicaid budgets could pay providers market rates, which would improve quality and relieve caregiver shortages. Families would mobilize to help elders plan and to protect inheritances by avoiding Medicaid instead of taking advantage of it. With most LTC funded privately, families could turn over the heaviest and most intimate personal care to paid caregivers. Nursing homes would provide subacute and rehab care, but long-term custodial care would devolve naturally toward home care as market-based consumer preferences prevail. The challenge to achieve these benefits may not be as great as we once thought. Research by one of today's interlocutors, Dr. Johnson, found that while 56% of people turning 65 will need LTC, 44% will not. The average $121,000 cost for those who do need care, 43% of which Medicaid pays today, could be financed by setting aside the present discounted value of $70,000 at age 65. Starting earlier, even less would be needed. We also identified substantial wealth held by aging Americans that is untapped for LTC, just locked up in home equity, $12 trillion, retirement savings, $35 trillion, and life insurance, $21 trillion. By mobilizing this wealth to fund LTC, reliance on Medicaid could be drastically reduced and access to quality care vastly increased. But that objective faces two obstacles. First, that wealth already supports other worthy goals, such as estate planning, retirement savings, and life insurance. Second, young families saving for retirement while making car and mortgage payments cannot assume the added burden of LTC planning. We resolve those two challenges by prioritizing LTC among life's risks and offering ways for people to meet their planning objective more easily. LTC is the biggest financial risk aging people face. but Medicaid obscured that fact. Granting LTC top priority, public policy should allow people to meet their planning responsibility by earmarking wealth they are already accumulating for other purposes to be used first for LTC if needed. We propose 7 LTC choices to help them do that. LTC choice number 1 recognizes that private insurance would be more affordable, covering only average risk. Choice number 2 proposes a new tax-favored account for LTC. Numbers 3, 4, and 5 would enable people to earmark part of their home equity, retirement savings, and life insurance for LTC if and only if needed. LTC choice number 6 does the same for estates, and number 7 favors people who start younger with more easily attainable goals. With average LTC risk and cost handled in the private market, the burden on Medicaid will decline substantially, but not disappear. Medicaid for catastrophic coverage will remain, but only for the truly indigent whose savings have actually been consumed by private LTC expenditures. Exploding Medicaid costs and the service delivery and financing dysfunctions they caused are undesirable and insupportable. What could be more reasonable than to solve them by converting Medicaid into the program most people think it already is? That concludes my remarks. Thank you.
Thank you, Steve. And for those of you in attendance, we're going to be hearing in a moment from Richard Johnson and then Mark Warshawsky. And then I'm going to be moderating a discussion among these people who have different views on all of this and opening up some questions. And I've got some questions too. But before I introduce Rich, Steve, I'm going to catch you by surprise here. You can only answer with one word. You've been on this beat now for 30, 40 years. And yet the progress I think you were hoping would have happened hasn't happened yet. Why not? One word.
Well, I can't do it in one word. Social insurance. I think that lure has prevented policymakers from really thinking clearly about what the options might be that are market-based.
Thank you. Let me take a moment now to introduce a reactor, but also a brilliant thinker in certainly his own right. After getting his undergraduate degree at Princeton, went on and got his doctorate in economics in the University of Pennsylvania. Richard Johnson is a senior fellow in the Income and Benefits Policy Center at the Urban Institute, where he directs the program on retirement policy. And his knowledge about the retirement issues is deep and vast. His current research focuses on older Americans' employment and retirement decisions, long-term services and supports for older adults with disabilities, and state and local pensions. Recent studies have examined job loss at older ages and its impact, the financial and health risks people face as they approach retirement, the affordability of long-term services and supports, and the potential impact of various Social Security reform proposals on future retirement income. Rich, we are delighted and honored to have someone, and by the way, I think you are at 60, the youngster on our program today, someone of your vast perspective and knowledge. Love to hear your thoughts about what Steve just said and where you think we're headed.
Great. Thank you very much, Ken. And I'd like to thank the Paragon Health Institute for organizing this important session and inviting me to participate. And I'd like to congratulate Stephen on his 2 recent reports. I think they provide a very useful description of the long-term care problem that confronts our nation, and they include some interesting policy ideas to improve the financing and delivery of that care. I hope that these can jumpstart a national conversation about the best way to move forward. Now, as Stephen points out, the risk of becoming frail at older ages and needing long-term care is significant, and that care can be quite expensive. The risk of needing long-term care increases rapidly as people reach age 85, but it's important to keep in mind that not everyone who lives that long will need care. Estimates that I've developed from longitudinal household survey data that differ a little bit from the results that Stephen cited of mine from another study indicate that 16% of people ages 65 and older today have serious long-term care needs, including 40% of people ages 85 and older. About 8% of people ages 65 and older now receive some type of paid care, so either nursing home care, some other type of residential care, or paid home care. And 26% of people ages 85 and older receive some type of paid care. So those numbers have been pretty stable over the past. My apologies, somehow I muted myself. So those numbers have been pretty stable over the past 20 years, except that we've seen a shift in the type of care that's being provided. So a shift away from nursing home care toward assisted living and toward home care. So the majority of people, even those at quite advanced ages, do not need or receive long-term care. Now, the prevalence rates are much higher when we look over a lifetime. So we estimate that about 70% of people who survive to age 65 will develop serious long-term care needs before they die, and 48% will receive paid long-term care. So about half the population will never use paid long-term care. Now, the gap in the estimates between those who ever need long-term care, that's 70%, and those who receive paid services, 48%, highlights the central role played by family caregivers in the provision of long-term care. Many older people with care needs rely solely on unpaid family members to care for them. Just as important, nearly everyone who receives paid care also depends on family members to supplement that care. Let's say coordinating paid care, managing finances, running other types of errands, and supplementing hands-on care. Providing care often creates significant financial, physical, and emotional burdens for caregivers. Many estimates of the cost of long-term care consider only paid care, thus ignoring an important component of the long-term care infrastructure and underestimating the true costs involved. So when we think about the cost of providing more care, we need to remember the benefits that would likely accrue to family caregivers, including the potential impact on their paid employment and the positive spillover effects from their being able to work more. It's also important to remember that the risk of long-term care is not spread evenly over the population. Women are more likely to need care than men. People of color are somewhat more likely to need care than non-Hispanic white adults. And importantly, less educated and lower income adults are more likely to need care than those with more education and more financial resources. The duration of long-term care needs are also distributed unevenly over the population. So most spells are relatively short. So among people with serious long-term care needs, 40% of spells last no more than 2 years, 62% last no more than 4 years. Among people receiving paid care, 49% receive paid care for no more than 2 years, 72% receive paid care for no more than 4 years. Yet, serious LTC needs last more than 10 years for 9% of people with needs, and paid care lasts more than 10 years for about 5% of people who receive care. So there is a small group who need a lot of care and for whom that care is quite expensive. These risk disparities should inform potential policy solutions. So the fact that people with fewer resources are more likely to need care complicate efforts to promote self-financing of care. Household wealth and home equity fall sharply when older adults develop severe disabilities or receive nursing home care, suggesting that many people with long-term care needs do have some skin in the game. Just as important, older adults who develop serious disabilities in their 50s, 60s, and 70s, and those with extended nursing home stays have substantially less wealth than other older adults years before they develop disabilities or begin receiving care, suggesting that proposed policies designed to encourage people to pre-fund future long-term care expenses may have limited impact because they will be unable to target those with the highest expenses. So a few years ago, I looked at people ages 51 to 59 in 1992 with no disabilities at that time and whose spouse, if they were married, didn't have any disabilities. And I divided the sample into those who would go on to develop two or more limitations within the next 20 years, and those who did not, who never developed disabilities over that 20-year period. And median wealth was 61% higher for those who never reported any limitations over that next 20 years than those who did. Median total household wealth was only $139,000 in 1992 for those who went on to develop serious needs. So many people who don't have income, many people don't have income to cover home care if they need it. We found that only in a recent study, only 40% had enough income to cover a moderate amount of home care, about 90 hours per month. The share with enough income to cover home care fell to 22% among those with significant long-term care needs. It fell to 25% among Black people, 26% among Hispanic people. Now, people with inadequate income could spend down their other resources to finance care. The median number of months of home care that could be covered that way is 43 months, so more than 3.5 years. So that's more than as we saw, as I expressed earlier, more than the median time people will need care. But the median number of months that could be financed that way falls to 16, less than a year and a half, when we consider only people with significant LTC needs. So given the difficulty that many people who need care would face in financing their own long-term care, I think there remains an important role for government to play in providing a safety net for people who become frail at older ages and need help. Thank you.
Thank you, Rich. I'm going to do a sort of a lightning round. One question for you before I introduce Mark. You've got such a depth of understanding of the numbers and the flows and the needs and the inequities. There were one thing you'd like everybody viewing this call to be more cognizant of. Now, I know there's not just one thing, but if there were one thing that you'd like for people to be more cognizant of, what would that be?
I think the one thing I would emphasize is the heterogeneity among the older population, and in particular that there's a lot of people who are going to be just fine, but there's a small group who are going to develop serious long-term care needs, and many of them simply do not have the funds to prepare themselves for that eventuality.
Thank you. Dr. Mark Warshawsky, after starting out with his undergraduate at Northwestern, went on and got his doctorate at Harvard in economics. Mark is a senior fellow at the American Enterprise Institute, where he focuses on Social Security and retirement issues, pensions, long-term care, disability insurance, and the federal budget. Before joining AEI, Dr. Warshawsky served as Deputy Commissioner for Retirement and Disability Policy at the Social Security Administration. Earlier, he served as a member of the Social Security Advisory Board, Vice Chairman of the Federal Commission on Long-Term Care, and Assistant Secretary for Economic Policy at the United States Department of the Treasury, where he had a key role in the development of the Pension Protection Act of 2006. I have spent the last number of days in preparation for this session watching both Steve Moses, Rich, and Mark videos that can be found on YouTube. And Mark's understanding of all of these issues is extraordinary. So, Mark, I'd like to hear your reaction to these two reports and what you've heard so far and what you're thinking about all this.
Thank you, Ken, and thanks to the Paragon Institute for inviting me. I have read both papers by Steve, and I'm very impressed by the papers and more broadly by Steve's long background in this topic. Every time I read something by Steve, I learn something new, and that's certainly true in these two papers. Largely I agree with him, particularly on the problem. I think he has accurately identified the Dr. Jekyll, Mr. Hyde aspect of Medicaid for long-term care benefits. Although on the one hand, it is marketed and it's understood in the public mind and among policymakers as a program for the poor, when it comes to long-term care, the reality is that it's a program for not just the poor, but for the middle class, the upper middle class, and even the wealthy. And I think Steve has identified that very, very effectively by noting that there are all these planning techniques that you can use to become eligible for Medicaid, even if you have a lot of assets and high income. You just look on the internet and type in Medicaid planning, and you'll get literally hundreds of lawyers that will tell you how to do it. But even without hiring a lawyer, there are some very simple ways of becoming eligible for Medicaid with significant income and assets, and that is, as I think has already been indicated, the value of your home is excluded from the assets that otherwise would, you need to be very poor, nominally to qualify for Medicaid. But if the home value of 700,000 over $1 million, and in California, no limit, well, you're rich. And that's not just the only assets that's often excluded. Retirement assets, 401k plans, IRAs, and so on, in many states, not in all states, and the rules are complicated. They differ from state to state, but in many states, your IRA and your 401k is also excluded from accountable assets. So you don't even need to. I mean, that's where most of their wealth is contained. So you don't even need to hire a lawyer, though. If you have $1 million home and $500,000 in IRA, you're eligible. Now, as Steve indicated, there are also income limits, but they're very high because it is because of medical necessity. So in a nursing home's costing what they do, easily $100,000, $120,000 a year. Most people do not have that income, and so they're eligible, even if they have a lot of assets. And furthermore, when people age, their incomes go down. But really, we have to really view people's ability to pay for long-term care in terms of their assets. So I think Steve has got it quite right that really the focus is on developing assets and developing and the use of assets that have been saved and should be saved in order to finance long-term care. There are just a couple of instances where I do disagree. I'm not sure that there used to be an institutional bias in Medicaid. Where basically you were encouraged to go to the nursing home and not pay for home care. That has been changed very rapidly over the last 10, 20 years. So much so that in some states, I think the pendulum has swung in the other direction. That very expensive home care, basically, $30,000 a month, full-time 24/7 care is being paid for by Medicaid. But clearly it would be much cheaper if it were, and maybe more effective if it were done in a nursing home. The other thing in terms of the unpaid family caregivers, which we have talked quite a bit about, I'm not sure it's a matter of excessive reliance on those family caregivers, but I think it is true, and I think everyone will agree with this. With birth rates down, basically the birth rate, there's fewer children. And that's going to affect both the current generation on approaching retirement, and it's going to affect the people, the next generation as well. And so basically, it's simply whether we want to or not, we won't be able to rely on family caregivers, and so unpaid. So the need for paid care is going to grow, and that really will impact the budgets. I don't think the official scorekeepers have really recognized this fact in terms of scores of various proposals and just the current setup. We're going to face, as governments and as individuals, increasing bills for long-term care. And this is at the same time, which again, Steve emphasized very appropriately, that Social Security and Medicare, other government programs are totally inadequately financed, and we have to deal with that. And government deficits are gigantic. The debt is gargantuan. It's very unlikely that we will ever see any social insurance programs for this problem, long-term care. And so we really have to solve the problem, I think, as Steve has indicated. I don't know if I've gone over my time, but I would like to, at some point, address Steve's solution as well. I have some agreements and some disagreements with his proposed solution. Thank you.
Thank you. Mark, I'll ask you one lightning round question, and not concerning yourself with the political favorability of this question. As you have examined life expectancy, aging, all these programs, perhaps more than any living person, If you had to pick an age today to mark the beginning of old age, what age would you pick?
I think it would be 70.
And I'll double down on that question because I keep reading about programs that are geared to 65 being the marker of old age, having, a decade of life left in them or less. How come this issue is not being talked about more and brought up in the political debates and presidential runs for decades? Questions have never been asked about this.
Well, I'm not sure that it's quite true to say that it's never. It is certainly it's easy to demagogue, and there are groups. I mean, I think Rich was right that if you cut the population in such a way, there are groups where 70 would be considered old. People are disabled or very poor. But for the vast majority of Americans, 70 is the right age. And you need to design these big programs like Social Security, Medicare, and so on, Medicaid, based on the average, and then you try to design other programs that will address the smaller populations. But you don't design big programs for small populations. That just doesn't make sense, and it becomes way too costly. I mean, that's the biggest problem with that approach, is that you just can't afford it.
Thank you. So our remaining half an hour, we're going to take the gloves off. And if folks have questions, send them in. I've already gotten a handful of questions. So I'm going to start. Steve, what's happening with the private long-term care insurance market that you favor? Like, how are they doing? Steve, you're on mute. We can't hear you. Thank you.
I was saying long-term care insurance ran into a big brick wall of public policy. Medicaid gave away what they were trying to sell. The Federal Reserve set interest rates so low that the carriers were unable to get enough return on their reserves to pay benefits without raising premiums. And when they raised premiums, they lost customers. Everybody got mad at private insurance. And I always ask them to realize that they're at much greater jeopardy from the big public programs like Social Security and Medicare, which are also in danger of being unable to pay their premiums, pay benefits, but are doing nothing about shoring up their credibility. So I do think long-term care insurance could be a bigger part of the solution. And I've suggested in the report that we limit it to insurance against average risk instead of catastrophic risk to make it more affordable as one of the LTC choice solutions.
Okay, I just heard your answer, and that did not make me feel comforted that the industry is doing well and will do well in the years to come. What advice would you give that industry?
Well, I would advise them to get behind public policy proposals that will get their biggest competitor, Medicaid, out of the way and give them some running room. The industry has been very reluctant to do anything, as insurance companies always are, reluctant to stir the pot. But I would recommend that they get more active in the public policy area.
Thanks. Rich, if you were the master of all things and you could wave a wand and make things good for generations going forward, and keeping in mind a very critical point that Mark made, which is when the boomers' parents were having them, they were averaging 4 kids each. So that generation, who is very old right now, if they're still alive, had a lot of kids to call upon for help. We're going to have a caregiving crunch because the boomers only had half as many kids. And so as the boomers reach their late 70s, 80s, and so on, and at the end of this year, there won't be one boomer under the age of 60, there'll be a shortage of family caregivers. So if you could wave your magic wand, what would you do to create a solvency for long-term care funding? Would it be government? Would it be the private sector? Would it be personal savings? Would it be change retirement age? What would you do?
I think it's a combination of all of those things. I mean, I very much support many of the Medicaid reforms that Steve talked about. I think we want to focus those Medicaid resources on people who really have limited income, have limited resources, and we don't want to have them going to upper middle class people. And I think I think it was really important for Steve to highlight that problem that we have. But I also think that's reducing the role of Medicaid, and also, as he said, I think very importantly, that the Medicaid reimbursement rates being so low, that just reduces the makes makes it hard for them to cover their costs, and just has a ripple effect throughout the long-term care industry. So I think all that's really important. But I don't think that fixing those issues, which need to be fixed, is going to completely solve the long-term care problem. And so I'm a little skeptical of the long-term care insurance being playing a very large role. I think for certain people it makes a lot of sense, but we do have the problem that many people are unable to purchase long-term care insurance in their 50s because they have because they have pre-existing conditions. And then just encouraging people to purchase long-term care insurance has always been difficult. I don't really see that problem going away. I mean, most people think long-term care is covered by Medicare. So if Medicaid becomes less important, I don't think they'll say, oh, well, now I need to go buy private long-term care insurance. I mean, we could try to educate people, but I think that would be a challenge. I would not. So I should also say that I'm very cognizant of the long-term financing problems we have. And there is a real issue about how much resources do we want to devote to older people versus younger people. That we underinvest in children dramatically, and so how much more do we want to give to older people? That said, we did expand Medicare a decade or so ago. Well, I guess now it's 2 decades ago, with prescription drugs. Maybe it's time to provide more coverage of long-term care through Medicare. And I think there are ways it could be structured. One of the concerns is, well, long-term care is something that everyone can use. And so there's this woodwork effect that, people come out of the woodwork once there's a benefit. Now everyone all of a sudden wants free home care. What long-term care insurance policies do, though, is they restrict the amount of care you can get. It's over, a certain period. Medicare could maybe think about doing something like that. That's been found, at least in the private insurance, that those types of limits really make people think twice about using their benefit before it's absolutely necessary.
Okay, I've got a question of the three of you, several questions. First question is, there's healthcare and then there's long-term care. I travel in some circles where people say there's really an integrated continuum of care and things ought to be thought about that way. Where do you come out? Mark, do you want to go first?
Yeah, well, I mean, there's certainly an aspect to that, and certainly for some people that is definitely true. However, and this relates to whether long-term care insurance is a viable product, and it really relates to your question, and that is, can you design, and that's true also actually in terms of whether it's public or private, can you design a program that can ensure for long-term care that isn't just doesn't bleed into healthcare more broadly? And I think the answer is yes. You can define it, pretty tightly, and that it's for, and I think it's being done. And so it's, if you have 2 of 6 inability to perform 2 of 6 activities of daily living, or if you're cognitively impaired, I mean, all these triggers for benefits can be designed, and it's not healthcare per se. So I think it's done. I think the problem with long-term care insurance, as Rich indicated, certainly there is the underwriting problem, which some people simply can't get it. The other thing is that the cost has gone up, and as Steve indicated, interest rates are part of the reason, but I don't think it's the only reason. I think part of it is that there is this there's a moral hazard that if the product is not well designed, people will claim benefits more so than what was in the price. So I have some proposals, which is we don't have time to discuss, to make that product work better. And I think that is part of the solution, is to have a truly working, viable long-term care insurance product, private market to work. Thus far, it has not been a total success. It hasn't been a failure, but it's not been a total success.
Rich,
Well, I'm
and
not
then,
here
or Steve, go ahead.
to defend long-term care insurance. I've always thought it's an important product and it should be part of the solution, but only part of the solution. That's why I focused more in the solutions paper on the wealth that's already out there in the economy that is lying fallow. It's unused for long-term care. And if we can bring that private financing into the marketplace and let people make their own decisions how to spend it, then we can finally finance a continuum of care where people are able to get the home care they prefer when that is enough to satisfy their need, and then they can move up the scale of care and get only nursing home care when they really need it, instead of being warehoused in these places for long-term custodial care. It's bringing in new money that hasn't been there before that is so critical. And once we do, if that money is really at risk, as it has not been, then there will be a larger role for private insurance as well.
Steve, before I hear Rich's thoughts, just for clarity, as you look at this situation, measuring people's wealth and ability to pay for long-term care, however they do that, using income is one approach. But when you look at the amount of home ownership, which is quite stunning among older people, and if you look at insurance policies and you look at savings and other family wealth inheritances, your belief is that if that whole pool were more known about and were more tapped into, a lot of the problem would be handleable.
There's more than enough wealth in the American economy to provide quality long-term care for all aging Americans. We just don't access it. But we do need public policy that would make these resources that are already dedicated to Social Security, Medicare, all these, the money that we're paying in, if we make some of that available to people, if and only if they need long-term care, and if we learn from Rich's idea of the present discounted value to actually set aside a set amount early and earmark other sources of financing, including home equity and estates, for that purpose, if and only if needed, then we're giving the proper priority to long-term care. We have not given it the priority it deserves as the biggest financial risk seniors face, simply because Medicaid has obviated the need to prepare for it.
Thank you. Rich, what are your thoughts about this theme?
Well, I think the idea of getting people to set aside money early is great to cover their future costs. I think the problem is that that works well for maybe half the population. But you look at a lot of people, we look at these projections about income and wealth for the older population going forward, and there are some real, there's a lot of debate about this, really. How do we think, how well prepared are people for retirement, and how is that moving forward? What is that going to look like moving forward? But there are a lot of headwinds that I think older people are facing, and subsequent generations, and we have seen wages for men at least, except for those at the very upper end of the distribution, average wages, median wages have been stagnating. And so that limits people's ability to save for retirement. we have more people entering retirement with substantial debt than we have in the past. That debt has to be, so now they need to take their retirement income and service that debt. So, while yes, some people have a lot of resources tied up in home equity, they could use that to cover their long-term care costs. But then those who have the highest costs and who need long-term care the longest tend not to have that much wealth. And so, I still think we need to think of, so Medicaid could, be dedicated more to those people. That would certainly be an improvement. I'm not sure that is enough to really solve this problem.
Okay, so there are lots of questions coming in, and I'm going to ask that we go into more of a lightning round and quick answers. Will the trend of states adopting long-term care programs mitigate or worsen the problem of people improperly preparing? Who'd like to answer that?
Well, let me
Mark.
start. Yeah, let me start. So there's one state that does have a long-term care insurance program. That's Washington State, and it's actually now running. It's very unpopular. People are very opposed to it because they see that it's a very small benefit for a very high tax. It's a payroll tax, and a lot of people don't think they're ever going to get the benefit because they're going to move out of the state when they retire or at some point during their life, and they'll never see a benefit. And it's very evident that it's unpopular because initially people claimed they had long-term care insurance, private insurance. They were exempt from paying the payroll tax. Fully 500,000 workers in Washington State said they had that insurance, which was not true. It's impossible. Nowhere near that many people have private long-term care insurance, but they claimed it anyway. So the government basically encouraged people to lie in order to avoid paying the payroll tax, which is a terrible public policy.
So you're not keen on the Washington State program?
No, bottom line, no.
Well, just a clarification on that. What happened was that Washington State gave people the opportunity to opt out of the program by purchasing long-term care insurance. And there was a sudden huge demand for long-term care insurance that overwhelmed the market and scared the carriers that people were just buying a little bit of insurance to evade the tax, and they would drop that insurance quickly, creating a massive administrative cost. So yeah,
Okay.
you're right in principle, Mark. But I think there was actually a huge demand for that product.
Yeah, no,
That is a lesson that is well learned because imagine what would happen if people suddenly were confronted with the reality that they have to plan personally and responsibly for long-term care. That is evidence in Washington State that the demand for private insurance would skyrocket.
All right, next question. All of you have mentioned the idea that people ought to be thinking about long-term care earlier in their life, not the day that they slip and fall. Who's responsible for educating and motivating and alerting the population? Who ought to be? Anybody?
I've been doing my best, but for a long time, but it's very difficult because as long as people can ignore the risk, avoid the premiums, wait until they need it, and get the government to pay, there's little reason to expect them to plan early. So that we have to start with a change in the public policy so that people can't ignore the risk and get government to pay. And once we do that, you won't need to educate them because that reality will impinge.
Rich, how would you answer the question as to how do you get people earlier in their life thinking about the end of their life?
Well, I mean, one obvious solution is to have a mandatory social insurance program. You require people to set money aside, and the problem can be taken care of. Now, when you have exemptions, I mean, so there is this problem that some people have done the right thing already, and they went, or the right thing for them at least, they went and they purchased private long-term care insurance. Now to say, well, and on top of that, you have to participate in a social insurance program doesn't seem right. But I think there are, different ways of handling that than better ways of handling that than the state of Washington did. I think, there is some, maybe additional thought need to be given to having government play a bigger role in this. But government sends lots of other kind of signals to us. They try to educate us about the best time to take up Social Security benefits, and we have seen people taking up Social Security benefits later than they used to, and that's generally thought to be better for most people. So I think government can play a role. I think employers can play a role. Employers can offer private insurance plans. That way, people often trust their employer. So I think the combination of civic groups, of employers, of government, all working together could increase awareness substantially.
Thank you. Mark, your thought about how do you get people in their 20s and 30s and 40s thinking about their later life?
Well, we do have a good example of success in private pensions and retirement savings, and that is because it has been set up both by employers, but also very much encouraged by the government through tax incentives. And so I think applying some of those lessons for success, to this problem, I think would work. So I mean, the issue with tax incentives is that long-term care insurance does not have much of an incentive currently, and so that is certainly an issue which is holding it back. I think the other thing is, the Medicaid rules are so incredibly complex and they differ from state to state that we need a wholesale simplification. And this, the states who do manage these programs do need to educate people. These rules are way too complicated. They need to be simplified, and they need to be rationalized. And and when you do that, if you then at the same time you close all these loopholes. So because the loopholes are just not defensible, but they're there because no one knows about that.
Which loopholes would you close?
Well, I think, for example, excluding retirement assets from countable assets for eligibility, that would one I would close immediately. It's so unfair. Retirement assets are there to help fund needs in retirement. Long-term care is part of that.
What other loophole would you close?
I think another one is these in California, unlimited assets. We have to put limits on assets that make you that enable you to be eligible. That loophole is gigantic, and it's so unfair. Unlimited assets, you can be a billionaire and get onto Medicaid. That's craziness.
And what? Let me interject. It's more problematic for reasons we haven't talked about yet. One is the growing problem that's pointed out of structural LTC racism. It's not just the problems with Medicaid long-term care. They affect whites and marginalized groups as well. It's just that it's easier for affluent people to avoid the worst of what Medicaid provides. People are advised by their lawyers to preserve what they call key money so they can pay privately for a little while, which gains them access to the very nicest nursing homes and the best home health agencies, which are all desperate to attract private payers at half again as much as what Medicaid pays. So it has the effect of impacting socioeconomically underprivileged groups a lot more than it does affluent whites.
Steve, I've got a question just came in for you that builds on this point you're making. If you had a marshal support for a single policy in your solution, what would have the most significant impact? Would it be the home equity side of things? Steve?
Well, I'm thinking probably home equity. That's the biggest, most accessible repository of wealth that's out there, and I say it's accessible because there are reverse mortgages and home equity loans that enable people to access that, and it lends itself to being able to stay at home by taking resources. Use the home to stay at home. That's the way the National Council on Aging described it in wonderful work 10 or 12 years ago that has since gone off the radar screen.
So what, Rich and Mark, what should Medicaid be in the future?
I would say that it should be very much a program for the poor, so it should be designed, to be strict in terms of that it's for the poor, and it is also for catastrophic expenses, but it should not cover the middle class and certainly the upper middle class and the rich for ordinary expected long-term care needs. That's totally inappropriate. Those, another aspect, which, in terms of structural racism, in terms of Medicaid, you're because Medicaid is being so famished for funds because the expenses are so high for people who really don't need it. The people who truly do need it, not just for long-term care, but people who are disabled and others, they're not getting the right care that they deserve.
Thank you. Rich, what would the ideal Medicaid be?
It'd be similar to what Mark said. I don't disagree with that. I mean, I think I'm not sure how Mark defines poor. I mean, I would move it above the federal poverty level, so maybe 150% of poverty. More like what some of the Medicaid expansions under the ACA set eligibility at. I also, there's some discussion earlier about medically needy. In other words, allowing people to basically subtract from their income expenses that they used for care to establish eligibility. I do think that's important because, in a situation where someone who has a fairly large pension, but that's not enough to cover that's above the income threshold for Medicaid, but it's not enough to cover their nursing home, would then not be eligible for Medicaid. But yes, I would certainly restrict it to people with limited incomes.
All right, so we're getting down to our last question or two. So quick answers. All of you have mentioned that a certain amount of long-term care is provided by facilities or by paid professionals or lay professionals, but that the predominant contributor to people's long-term care needs are their family members. What would you do to help out the daughter or son or grandchildren who are helping mom or dad out by writing checks or by missing work or by having to not take a promotion or relocate because they're committed to being good family members? What would you do to help the families out? For example, last year there were 25 million people that had women that had a child in America, but there were 40 million people became elder caregivers. There's a lot of people who are providing care for a loved one. What would you do to make their lives more secure?
Most of us at the ages of the people on this panel have been through this, and it's a wrenching experience caring for parents and other relatives. I don't see this getting better by any kind of change in public policy other than to change the incentives in the system so that people save, invest, or insure and are prepared when the time comes to get help, so that the families, when they provide care, can give love and support and attention, but not have to change diapers and do the more intimate kinds of care.
Thank you. Mark, and then Rich.
I'll just be quick. I basically agree with what Steve indicated.
And I would just say, I think the role for government could be providing training to caregivers. I think people just need more information. I think people, if they're trying to get help, trying to get paid help, they don't know where to turn. They don't know what kinds of resources are available. So I think just more information is probably the best thing that one can do to help caregivers.
My last question, as was mentioned, although we didn't dwell on it, women generally outlive men by 5-6 years. So, and the average woman, if she's partnered with a man in America, the man will be 2.5 years older. That's harkens from an earlier time in history where the man had to get going earning the living. Now things are rebalancing in different ways. But if the woman then cares for her husband in his final years and he passes away, often draining her financially and emotionally, who's going to care for her at the end of her days? You mentioned inequality based on race or gender or economics. What about, race or economics? What about the gender issue? Who's going to help look after the women?
Well,
Yeah.
I'll
Please.
I'll anticipate what Steve is going to say. They need to, they need to be planned for, and that is part of a reasonable expectation that women live longer than men, that women, their wives are going to take care of their husbands, and therefore then there needs to be the asset gathering needs to anticipate exactly that in order to protect the wife as she ages.
Rich, were you going to add something?
Yes, this is long-term care is really a women's issue. They're the people most likely to provide care. They're the ones who are most likely to need care and most likely need to rely on paid caregivers. Spouses provide the bulk of care when spouses are available, and when they're not, people rely on their children. So most women, older women, do rely on children for care. But as we said, fewer children available. Many of them are working, so there are real challenges.
Thank you. So in a second, Brian is going to reappear and close this out, but let me offer a thought or two. First of all, the level of detail and depth that you folks have given to this and is reflected in the Paragon reports that Steve has crafted deserve a lot of attention. Second, this program has been recorded, so if you want to catch it again or catch parts of it that went by too fast, Brian will talk about when that'll be available. Some of the areas that I'm hearing are more thinking about the future, both societally, demographically, and family and individually is critical, and more educating with language and user-friendly constructs, whether that's employers or states or federal government. Leadership is needed there. And I think what I've heard is that Medicaid was initially well-intended to help those who were truly poor, but people have kind of masterminded ways to cut into it that could deplete the system way before its time. And that's got to be halted. And last, if there was a more active and fluid marketplace, when we looked at the whole family wealth or community wealth or individual wealth, there are resources available that could be deployed to pay for long-term care that need to be thought about as such. Brian, how would you like to close this out?
Hey, first of all, thank you, Steve, for doing the two papers and forming the basis of our discussion. Thank you, Mark and Rich, for providing really thoughtful commentary. And thank you, Ken. I thought that was an excellent moderated discussion. There was a lot to cover, and I think you did a really good job of getting through the material. A lot of audience engagement, so thank you to the audience. We had over 100 participants, and we got 34 questions, which is really substantial for the engagement. We were able to ask some of them. Answers to others are contained in Steve's work, so I do encourage you to go to paragoninstitute.org, find those two papers. I put a link in the chat to sign up for Paragon's newsletters. About every week, we send a newsletter out. Tomorrow morning, we're going to send a newsletter out, which will include the link to today's video. Obviously, this is a hugely important policy area. I think Ken started by talking about life expectancy and the increase in life expectancy and longevity. That's a great development. Like, there's very few developments as great as the increasing lifespan over the past century, and the economic wealth and standard of living that Americans have now. It certainly presents challenges, and with the baby boomers reaching retirement and increasingly that age where long-term care are needed. That's one demographic challenge. And then Mark mentioned the other, which is the declining American fertility rate and the challenges that families are going to face because of that. I think long-term care is an issue. that most of us are going to confront either with a loved one or ourselves. I was really pleased with the level of agreement that I heard on some of the problems that need to be addressed by policy, including problems that Medicaid just should not be as easy for relatively affluent to be able to access, and the moral hazard that that presents. Again, I want to thank Steve, Ken, Mark, and Rich. Is an excellent presentation, and we will, look at doing another one of these in the future. The challenge is certainly not going to go away anytime soon. So thank you, everybody. Have a great rest of your day.